Good afternoon, and thank you for joining today's webinar. This is the latest in the series on COVID-19 and the liver. It's entitled The Clinical Research in Hepatology During COVID-19 Pandemic and Beyond. Next slide. My name is Nora Turow, and I'm from the University of Southern California, and I will be moderating today's session. I'm delighted to have you joining us for this webinar. Today's webinar is being recorded and will be made available on the AASLD website and AASLD's YouTube channel. Shown here is today's agenda. So I'll start with a few housekeeping items and provide an introduction to our speakers and our panelists for today. And then we'll have three short talks, one that I'll do as an introduction, followed by Dr. Locke and Dr. Allen. And then we have plenty of time today for a panel discussion, and we invite you to participate in that component. Next slide. We're going to be using the Q&A chat function for your active participation. So submit your questions anytime during the webinar in the Q&A box that will be at the top or the bottom of your screen. And we will be answering these questions at the end of the presentation during our panel discussion. Next slide. I'm very pleased that we have two webinar presenters today. The first is Dr. Anna Locke, who is well known to everyone. She's a past president of the AASLD and the Dame Sheila Sherlock Distinguished University Professor. She wears many hats, but at the University of Michigan, where she works, she is both the Director of Clinical Hepatology and the Assistant Dean for Clinical Research. And it's in that dual capacity that we're very pleased to have her be one of the presenters today. Next slide. And we also have Dr. Elena Allen joining us from the Mayo Clinic in Rochester. She is an assistant professor there and the director of the Fatty Liver Clinic. And she will also be the presenter before we move to the panel discussion. Next slide. Joining us for the panel are really to represent sort of the full spectrum of research and the elements that go into that are Dr. Michael Freed, also a past president of AASLD, the director of UNC Liver Center, and he's at the University of North Carolina at Chapel Hill. We also have Dr. Avril Shurker, who's the director at the Centers for Liver Disease for the NIDDK, and Dr. Andrea Reed, who's the associate dean for Student and Multicultural Affairs and the director of the Office of Recruitment and Multicultural Affairs at Harvard School of Medicine. Next phase. I also want to call on and call out the great contributions that the AASLD's COVID-19 Clinical Oversight Committee provides. The members are listed here. This subcommittee has really been the engine that drives many of the educational activities that AASLD has undertaken regarding to COVID. And so this is just one more of their offerings. Next slide. So I'm going to lead with a few comments really to introduce us to this topic of clinical research in the pandemic. Next slide. I think for many of us, we remember the day when we recognized that COVID-19 had arrived at our institution and what that really meant. Overnight, seemingly, all of the non-essential clinical research was put on hold. We had to halt new enrollment in our existing trials. All of the trials that were in the pipeline were put on hold, and there was this real shift towards thinking about safety of our patients and participants, safety of the study staff, and our own safety. There was a shift towards remote visits, how do we deliver drugs at home, and many other elements that we'll touch on today. And we also saw that the machinery for clinical research also shifted at our institutions with IRBs and our clinical trial units really mobilizing to support COVID-related studies and with really less resources available to support the non-COVID related activities. And clinical researchers, we were impacted as well, as we were called upon to shift our clinical responsibilities to help cover COVID and non-COVID activities, and also dealing with the challenges of balancing home and work related to our sheltering in place environments. Next slide. So for many of us, March was a period of great activity. Shutting down became kind of the big focus, and then there was a recognition that it would last a few months, and then we'd be moving back toward where we were. And I think we're all aware that that has become a very protracted course now with, in some cases, second waves developing. Shown here is data from the WHO site, which documents the daily counts. And you're all very aware that in the US, we're dealing with a second wave in terms of number of COVID cases. But clearly, every country is in a different place. And I put up Canada and France just by way of illustration that every country is having to deal with this. So our colleagues around the world who are doing clinical investigation are having to cope with it, whether they're in the first wave, the second wave, or anticipating even a third. Next slide. But most are in the phase of reopening, and shown here is a map from the New York Times from very recently, where they highlight states that are reopening, states that are pausing their reopening, and even states that are reversing their reopening. But it is to highlight that it's still a very dynamic situation where we really uncertain about the future. When is it going to be that we'll be back to normal in terms of what normal might be for doing clinical research? And it's likely to be a new normal. I think we all understand that. And it's going to vary by state, by country, by institution. Next. So that's, it's like a storm arrived in the sense of COVID-19 and its impact on clinical research. But with every storm, there's, every cloud, there's the silver lining. Next slide. So really what we want to focus on today are some of the good that has come out of COVID-19 in terms of clinical research, the innovation and creativity in study design and execution, this recognition of hybrid models for doing both on-site and remote visits and activities to achieve study goals. We've seen a greater role for EMR-based data and big data. And certainly I think it's been wonderful to see the flexibility on the part of sponsors, regulatory authorities, and the NIH in terms of their readiness and willingness to adapt to this very much changing environment for clinical research. Next slide. So really today's focus is twofold. One is to look at COVID-19's impact on clinical research in hepatology through different lenses. We're going to have two speakers, one representing earlier career versus later career. We're also going to look at phases, shutdown and reopening, and then try to look across different types of clinical research, from clinical trials to real-world observational studies to the use of big data. And in all of this, discuss the potential strategies that we have and that we're learning through this experience to sustain and expand clinical research in the post-pandemic era. And that will include some discussion related to disparities, which have really been laid bare by COVID, and so really have moved to the forefront of things that we're considering for the future. Next slide. Before introducing the first speaker, I just want to make you all aware that sort of hot off the press is a publication in hepatology entitled Clinical Research in Hepatology in the Pandemic and Post-Pandemic Era. This is an excellent and very comprehensive document that looks at all aspects of clinical and translational research in hepatology as evidenced by the figure on the right. And many of the aspects that we're going to touch on today are also discussed in some detail in that document. So I call your attention to it. I think it's a great resource and encourage you all to have a look at it. Next. And so to start off our speakers today, it's my great pleasure to introduce Anna Locke. Dr. Locke, as mentioned, has many titles, and we've asked her today to address the topic of adaptation in clinical research during the COVID-19 pandemic. Dr. Locke.
Well, thank you very much, Nora. It is a pleasure to be here with everyone and discuss how we adapt to the pandemic era so that we can continue our research activities. Next slide. So I will speak from the perspective of being an investigator, as well as from the perspective of research administration. How we responded to the sudden marching order of ramping down, and how we prepare for opening up clinical research again, and what are the adaptations that we need to make in order to survive as well as to succeed in the new era. Next slide. So in March, all of a sudden, COVID-19 hit And I still remember that day when we were told, okay, we're going to shut down clinics, we're going to shut down research, send everybody home, and everyone is going to stay at home. It was a moment of confusion, because not only were we told to shut down everything, we were also told that we may not have enough PPE to protect ourselves if we were to take care of patients. At that stage, those of us who were doing research, the only thing that we could think of were the patients involved in clinical trials, particularly those who are receiving treatment, and now what do we do with them? As we were trying to figure things out, there was invariable delay, and some of the patients were not getting their medications at the right time. There was pause, there was delay, and we need to monitor the patients for the safety, but we weren't able to see them, and all that we could do was to rely on the phone. Next slide. But as time goes, we realized that we need to do something, and it was making all these adaptations. We were still focused mostly on clinical trial participants, but no longer are we just saying that, well, we got to stop. We need to make sure that we can deliver medications to them safely. So we were actually arranging for couriers or even home nursing to allow us to deliver the drugs to the patients. We also need to try to do safety monitoring. So we all sort of jump on the phone, jump on the video, so that we can assess the patients. For patients who need to have lab monitoring, we either send them to the local lab, or in some instances actually arrange for home nursing to visit the patient's home and even to draw blood at home to ensure the patient's safety. After the first few weeks, we realized that we have a whole portfolio of research studies that were just as important, particularly the long-term prospective observational studies, where when we had a huge pause, we would not be able to determine what happened to the patients. We recognized that these gaps would have an impact on study outcomes, impact on enrollment, and so we invented new ways of doing things. We did remote consenting, we relied on electronic platforms to allow us to collect the data. Funding is always important for research. Now, fortunately, with federal funding, the NIH came up with announcements that safety of the patient is important. There will be extension of the studies so that we'll be given more time to finish the work, not necessarily more money, more time. The problem is many of us are also involved in industry-funded studies where we pay based on work accomplished. So when we paused and we had no activities, it also means that there was no revenue. And with no revenue, and the need to support our staff and pay the salaries, there becomes a problem as to how we can maintain our staff without having to lay them off. So many of us rely on whatever residual funds that we have from previous studies, philanthropy, in order to maintain the staff. We try to get our staff to continue to help us and support us from home, but not all of them were well equipped to be able to work from home. So there were all these concerns and worries. Next slide. So we went through different phases. Initially, it was abrupt lockdown. It was chaos. We didn't know what to do, but we weren't too concerned because we thought naively at that time everything would be back to normal after a few weeks. Next slide. But then the cases continued to increase. Our hospitals were filled with COVID patients. Some of us were pulled to do different clinical services. It was a moment of anxiety, fear, distraction, and we're just trying to figure out how we can survive. And research became less of a priority. Next slide. But then we settled down and we say, this is going to be going on for a long while. And life, as well as our work, have to go on. And we have to figure out ways of adapting. It's a new reality. We'll either succumb or we're going to thrive. Next slide. So fortunately, we had a lot of guidance from the FDA, from the NIH, and many of the universities also provided guidance. So our university actually provided guidance. Yes, we want you to stay at home, But if you can actually continue to do research studies remotely and use all sorts of measures that you can think of, those studies can continue. But there are also some studies that even if you have to bring your staff in and bring the patients in, you can continue if these are clinical trials that would offer potential for immediate benefit to the patients and or crucial safety monitoring is necessary. So then we scramble and find out what those trials would be so that we can continue to maintain them. As I've mentioned, many of us are not necessarily as well equipped to work from home, particularly our staff. And fortunately, institutes provide IT support. We have IT people who actually walk our staff through for hours to make sure that they can access the documents from home and help them get prepared. IRB was also very helpful in providing guidance on protocol modifications, expanded options for remote consent. An investigational pharmacy arranged courier delivery of investigational drugs to allow essential research to continue. Next slide. Now that things, although we're not out of the woods by any means, many of the states, as Nora showed, are still having a lot of cases. But we sort of know that this is going to be with us for a while. And certainly in some of the states where cases have slowed down a little bit, we're beginning to think, when can we re-engage human research? Unfortunately, it is easy to close down because at the time when it was closed down, it was like shut off everything. But ramping things up is going to be more complicated, slow, and we don't really have a playbook to follow. So at University of Michigan, we have determined that we have to do it in stages. There will be plans to start, and if things are not going in the right direction, we have to know how to revert back to an earlier stage. We have to guiding principles for prioritization and training in safe practices. So we develop policies that are campus-wide, and there are 4 tiers based on benefit to the individual participants versus the risk of COVID transmission. And we determine the start and stop of each tier to be linked to the number of new cases within our state, as well as the safety plan. We make every investigator and staff complete training on safe practice, and every team that wants to reactivate the study, they need to request and they submit a checklist. And we have a committee that approve and review and assign which tier that study belongs to. All this is being communicated to the IRB and the departments, and we do random audits to make sure that everyone follows the risk mitigation plans. Next slide. So this is what I mean by linking the activation to the statewide plan. So right now, state of Michigan is in the 4th stage where we think that things are improving but still unstable. Earlier on, we were in the uncontrolled phase, persistent spread, flattening, and we hope that we will be able to move to the containing phase. So we tie the tiers of the studies. So right now we can do tier 2, 0, 1, and 2 studies. But if we move to the containing phase, we can do tier 3 studies as well. And we hope that one day we can go back to the pre-COVID era and be able to engage in all types of studies. Next slide. So how do we determine the tiers? It is based on benefit to the individual participants because all the studies are beneficial in that they generate new knowledge, but it's really, does the individual participant benefit versus the risk of the COVID transmission, not so much the risk of the study interventions or procedures themselves. So if you follow the benefit level and the risk level, you'll be able to determine whether this study should be tier 0, 1, 2, or 3. And the risk is largely dependent on whether there is no interaction with the participant because everything is remote, or if this is entirely in the context of a clinical encounter and the research can be done by the clinical team. So those should be very low risk. On the other hand, if this is bringing the patient in, particularly if they're immunosuppressed, older patients, and the study involved procedures where the patient cannot use PPE, those will be considered to be high risk. Next slide. So how do we adapt? As I've mentioned, the benefit is largely determined by study design. So clinical trials would offer the patient potential for benefit, and therefore the benefit level will be 1 to 3. Observation studies will be benefit level 4, essentially no direct benefit. In many studies that we do, they involve adults. There will be some risk, and many studies do involve older adults. So we also make suggestions as to how we can modify the risk by giving people all sorts of suggestions as to how we can convert the study to be remote, both in terms of remote consenting as well as using remote platform to collect data. But we rely on our clinical team when the patients come in for regular clinical care to help us conduct the research protocol. And for studies that involve really high-risk patients, particularly immunosuppressed, we will consider whether we can temporarily withhold enrolling those people, but bear in mind that it could impact the integrity of the study because a certain subset of the patient population is being excluded. Next slide. Again, Institute has to be supportive of this endeavor. So IT continues to support, and our IRB has been extremely helpful in fast-tracking any minor protocol modifications, additions to study team, for example, adding the clinical team to the research team so that they can help out with the procedures, adding all sorts of options for remote consent. And investigational pharmacy continues to be very helpful. Next slide. But what are the challenges with the ramp-up? We've mentioned a lot of modifications to study procedure. For example, not being able to enroll the older patients, not being able to collect all the data because not all data can be collected remotely. Some tests, some procedures require that the patients need to come in. So it generates missing data, missing results. It also generates some disparity because not all patients are able to participate in remote consent or participate in remote data collection. And this may actually result in certain patient population being omitted or having data incomplete, and that can influence the ultimate conclusions. There's also challenges because we as investigators are not full-time researchers. We also have clinical duties. And as the hospitals ramp up, we were asked to work harder in order to catch up with the backlog of patients, which result in less time devoted to research. And as we bring the patients back for clinical activity, and we need to maintain social distancing, it also creates problems with space because clinics are no longer as capable of accommodating research patients, and we have to find space where these patients can be evaluated. Some of us have lost some ability to generate revenue because we had to have several months of pause. And if with industry-funded studies, no activities means no revenue. And there are many research teams that had to lay off staff, which means that there's less manpower to help us conduct the work. Next slide. So how are we going to deal with this new era now, as well as plan for the future? I think that we have to think of ways by which we can get out of this, as Nora mentioned, the silver lining. I think through all these few months, we've learned that in the future, when we design studies, we need to be more lean, we need to be more efficient, focusing on essential data that are necessary for outcome. And the ancillary studies, ancillary data that are not important, we might omit. We need to think of incorporating options for remote consent as well as data collection, maximize the use of technology, as well as direct transfer of data from participants to the study database. So there's a plethora of wearable devices, home monitoring devices with Bluetooth, whereby the patients can transmit data directly to the research centers. And even you are asking the participants to directly self-enter the data into the database. Going forward, Studies will have fewer procedures, less in-person visits, which might be a good thing because it would reduce the cost of the studies and it might even enhance enrollment. But there could also be unintended consequences in that not every patient is going to have equal access to technology or internet, and it might result in very disproportionate enrollment in the future. Next slide. As far as the study team is concerned, we also need to adapt. We've learned that it is difficult to thrive on our own. We need to collaborate. We need to rely on each other. And if we have staff that cannot work from home, but we work as a team, we might need to rely on other people's coordinated to help us out. We also recognize the importance of having a balanced research portfolio. So if you only have clinical trials, there may be times when studies cannot go forward. If you only have observational studies and the patients cannot come because they're considered to be less in top priority, that can also be a problem. So having a balanced portfolio would allow us to continue our activity, would also allow a more steady stream of funding. We also learned that we must be very, very careful about finance and budgeting so that we always have a little bit of cushion to help us ride out gaps in funding. And we all need to be adept in using mobile technology and make sure that all our documents can be readily accessed from secure storage platform remotely. Next slide. So COVID-19 has really created a lot of chaos, a lot of disturbance, but we can let COVID-19 destroy us, or we can use COVID-19 as an impetus for disruptive innovation. We've encountered that type of disruption many, many times in our lives. There are a lot of things that we were used to, and we would think that back then, if we lost them, we won't be able to survive. But when new things happen, it took us time to adapt and to embrace those changes. But if we are open-minded and we embrace those changes, we find that many of them, we love them and we can no longer live without them. So I hope that this is true for clinical research as well. Thank you.
Wonderful. Thank you so much, Dr. Locke. What a wonderful and really insightful view of COVID and all that we've gone through over the past several months. I'm sure that there'll be many questions related to some of the specifics that you highlighted, particularly related to some of the paths forward. I would just remind everyone that you can use the Q&A to submit your questions at any time during the webinar, and that we will be getting to those during the panel discussion. Now it's a great pleasure to introduce our second speaker, Dr. Elena Allen, and she's going to be addressing the clinical research in hepatology during COVID pandemic, but from the early to mid-career investigator viewpoint. Dr. Allen.
Thank you, Dr. Turo. Thank you for the invitation, and I'm happy to speak about my viewpoint. And I will start with a bit of a background to say that at the current time when the corona pandemic hit, I was halfway through a K23 NIH award, which involves prospective enrollment of patients with interventions and follow-up. So people have to be present here in clinic to undergo the study. And also from the perspective of a mother of 2 elementary school-aged children. Next slide. So my presentation will focus on 2 specific points as pertain to this viewpoint. One is that of funding and career development grants, and the other one is that of career advancement. And as you know, early and mid-career is a crucial time when our future trajectory depends on strategic timelines and grant submissions and publications and research projects. So when the pandemic hit, for example, I was very excited about launching a new prospective study, which would represent preliminary data for an R01 and also starting to write an R03. Next slide. So Of course, my enthusiasm came to a screech when everything stopped, and we all experienced this. We had closures of the clinical research units. We had less research time for some of my colleagues from other institutions. I know were pulled for COVID-related clinical roles. There were major disruptions in research teams. I have a team of coordinator nurses and statisticians, for example. Everybody moved home or got redeployed, so we did not have any more in-person meetings, and that can lead to lost momentum. Next slide. So in my world, everything felt as a car crash because a pause in clinical research hinders progress reports on active grants. Planned interventional studies for upcoming grants are uncertain, as patients may be hesitant to travel even as we start to ramp up and we have institutional support to cover those studies. People may not come. And delay in obtaining preliminary data for planned grants is really impactful at this stage. There were additional institutional cost reductions resulting in additional loss of research funds. So what we deal with was a major now what, which made us pause, pivot, and adjust timelines and research plans and look for opportunities to soften this blow. Next slide. And I'll present some of these which I found useful and I think will be important to share. I'll start with the main one, stating that funding agencies and specifically NIH were very responsive to these changes. And there have been several changes made at several aspects, from proposal submission and award management to revised procedures for peer review. Some agencies have extended the due dates for research proposals. NIH has updated policies on clinical trials in human research and several additional recommendations for researchers, which I will detail in the upcoming slides. Next slide. First, I'd like to share the NIH guidance on human research affected by COVID that we should use in implementing in our current study designs or future study designs. And these guidelines highlight safety, not only of the human participants, which was always the major point in NIH research, but also the research staff involved in clinical trials and human subject studies. So what we have to consider as we design new projects would be to limit study visits to those needed for participant safety or coincidence with clinical care, to conduct virtual study visits. So design all our studies in limiting the in-person visits as much as possible, and to implement flexibility for required laboratory tests or imaging needed for safety monitoring. And NIH will be flexible regarding project extensions and accommodating unanticipated costs, which may be occurring because of these guidelines. Next slide. A second important point for early to mid-career investigators is that there are accommodations for loss of research time, which are crucial for career development and training awards. K awardees can request extension or reduced research effort or leave of absence for a break in service, request which will be considered on a case-by-case basis. Second, extensions for early stage investigator eligibility due to these disruptions will be considered on a case-by-case basis. And early stage investigator, or ESI, is a crucial status for first R01 submission, and this is a time-sensitive status from the year of graduation. So this is a very important component of applications. Next slide. Third, NIH has revised their grant review process such that grants that were due in January of 2020 had a due date extension to May 1st. The reviewers on the study sections are instructed to assume that the issues resulting from the coronavirus pandemic will be considered prior to award. In other words, do not score or assess feasibility based on potential issues related to the pandemic. Next slide. For the grants which were due in May 2020, the preliminary data was allowed as a post-submission material, and this was up to 30 days before study section. So this allows some leeway for those delays that may have occurred due to this pandemic in obtaining preliminary data. Next slide. So NIH is keeping track of these submissions, and this document was released earlier this week, showing the number of R01 equivalent applications which were received in the May to June cycle in 2020 compared to the previous 3 years. And as you can see, the number of grants submitted has not decreased, actually on the contrary, and it's reassuring to see that the proportion of women and men have been relatively stable. The other column includes multi-PI grants, which include men and women. So I think the data for October 2020 will be more reflective of these slowdowns, teleworking, and school closures, because the grants submitted in the May-June cycle were the result of more than 6 months of work including prior to the pandemic. Next slide. So that concluded the funding part. I will move to the career advancement challenges, which I think are important and significant, because decreased face-to-face interactions due to canceled meetings lead to impaired scientific discussions and exchange, and also a potential impact on mentorship and networking, which is crucial at this stage. Secondly, working from home can lead to decreased productivity, especially for those who do have children. And so the responsibilities of working parents are exacerbated by this crisis. And I think disproportionately, women will be affected more by this new challenge because they are more involved in household and childcare demands, as previous studies have shown. Next slide. And this is one of the most recent studies looking at this, recently published in Nature. And this is a survey across several scientists, across several disciplines, looking at the unequal effects of COVID-19 pandemic on scientists. And if you look at the orange box, when all other demographics are equal and all the other things such as tenure versus no tenure or age, the most important factors that reduce productivity and impact research time are having young dependents, also known as children, and being a female. So these are major factors that have to be accounted at institutional level. Next slide. So this is new and uncharted territory for institutions who will have to brainstorm and implement policies for employee support to allow childcare flexibilities, which is a massive challenge for the institutional leaders, especially now when schools are finalizing their plans and the situation is unfolding. They should also consider these potential delays in publications and funding and extend tenure or promotion periods. And on our side, as investigators in the early to mid-career phase, we should be more proactive in requesting virtual mentorship meetings within our institution and other digital conferences, because on-the-fly check-ins, which are very important, are less likely to happen. So we just have to put more effort into getting that help. So my ending thoughts are that we cannot change these external factors, but we can be nimble and adapt our timelines and research designs to not allow this pandemic to impact our careers. Thank you.
Wonderful. Thank you, Dr. Allen. That was really the ideal complement to Dr. Locke's presentation. I think you captured the challenges faced by young and early career investigators, so thank you so much. I'm now going to move to the panel, and I welcome to the stage, as it were, in addition to Dr. Locke and Dr. Allen, Dr. Fried, Dr. Shurker, and Dr. Reed. And so let's get started. There's several questions that we want to try to get to here, and so I'm going to sort of launch the first one. And it's an important question, I think, because I think with all of the adjustments that have been discussed here and how we've been doing research through this time, I think what is a concern is that there's going to be a reduction in the integrity of data. So that may have implications for getting papers published, work published, because there's going to be these gaps. And the question is sort of, how do you feel this should be approached? How do investigators think about that? And there's a bigger question of like, what can we do in terms of lobbying journal editors and others to be more flexible about acknowledging these limitations of the data. And maybe I'll ask you, Anna, to start.
So yeah, one example is we're involved in an NIH-funded network in which the study happened to reach a time point where primary endpoint is being assessed, and the patients cannot come back for the primary endpoint. So normally we say, well, it's intention to treat analysis. Well, the patients don't come back, then they fail treatment. Well, it's not because they failed treatment, it's just because they weren't able to come back and get a testing done. So you can do all sorts of statistical gimmicks, imputation, and sensitivity analysis, but it's not quite the same. And I think that we hope that journal editors are going to really understand why we have to use some different strategies to sort of present the data in different ways. But it's also an issue that even though we cannot get the complete data, are there ways by which we can get partial data, getting local labs? Now, what are the assessments that we can do remotely through phone, through video? But it's this major challenge, and it impacts not just clinical trials, but even observational, longitudinal, natural history studies. A 6-month gap means that we miss what happened.
Thank you. Okay. No, I was going to put you on the spot, Dr. Fried. I think that you're going to be a reviewer for such papers, right? Many on this call are the reviewers. So I guess I'm going to ask you sort of, how do you view this? And I think we want to sort of speak to those that are going to be submitting about how you're going to think about these papers as a reviewer.
I think as we've heard, we've all been impacted by this. And I think we all have to be very reasonable and flexible and take all of these things into consideration for sure. I think that's only fair to all the researchers, all the investigators with all the time that they put into it, and the participants who really want to know the results of the studies that they're participating in and that they've contributed to science and advancing the field. Correct. So I think it would be useful for investigators, if they are faced with that challenge, to actually be very upfront about it, either in the cover letter to the journal or even in the body of the paper, explaining how COVID impacted how they might have evaluated their endpoints or how they had to adapt. And I think any reasonable reviewer should really respect that information and look upon it favorably.
Oh, that's a great suggestion. I'm going to shift because we've also got a very important kind of perspective about the patients and sort of how they're perceiving research during this time and what COVID and all the fear around COVID may do in terms of patients' willingness to participate, both in ongoing studies, but also new studies. And Andrea, I'm going to ask you to weigh in here as well about really the importance of us trying to reach out to certain populations and what's our ability to do that and how that may be impacted by what we've just gone through. So Andrea, do you want to start?
Sure. Well, thanks. I think it's really important to just highlight what you said initially, is that COVID really has laid bare so many of the disparities in healthcare outcomes that we've known about for a very long time, but now we're really on full display. And even as some of the early trials on COVID-19 therapeutics and then subsequently looking at vaccinations, there's been a lot of discussion around diversifying the population of patients for whom this is available. And it's really important to recognize that there's a reason why there's underrepresentation of certain groups within clinical trials. And it's based in two really important factors. And one is sort of historical significance of abuse, and then also access. So the issue around historical mistreatment by the US medical system of Black and Brown people is one that really cannot be overstated. And I think we focus a lot on the Tuskegee experiment in the 1930s to the 1970s, but even before that, there's been renewed focus on the fact that the father of modern OBGYN actually developed his techniques and tools on enslaved Black women without anesthesia. And then once they were perfected, used them on white women in Europe with anesthesia. And that's been, well known, but he was celebrated until very, very recently as the father of modern OBGYN. And then, forced sterilization of of Native Americans and undesirable citizens, including Blacks and those who were mentally disabled and poor. That continued for over 40 years in this country, sanctioned by the US medical system. And then, the Tuskegee study, in case people aren't aware, was actually sanctioned and carried out by the US Public Health Service. And that included over 400 Black men with latent syphilis who were enrolled in a trial for bad blood, and they were not treated, purposely not treated for syphilis, so that the US health system could figure out what untreated syphilis does. Unfortunately, those individuals were both lied to as to why they were put into the trial, thinking they were in a treatment trial. They were not given treatment, and even after penicillin was identified as treatment for syphilis, they were not able to access that. And so if you think, even those are historical, but then more recent things like the studies that have shown that medical students in 2016 think that because Black patients have thicker skin that they're less likely to experience pain and are therefore not given same doses of pain medication for the same complaints. So there are so many studies that have been carried out, unfortunately, that reflect what was abuse within the medical system, and that they're unfortunately not just historical. There are things that are more recent. So that's a big part. And then the second piece is about access. So where are the studies done? Who is carrying them out? So if we want to improve enrollment of these populations within studies, we have to think about who the investigators are. And do the investigators look like the patients? Why should they trust the investigators? Where are the studies being handled? And whether or not those individuals who get their care in community health centers and in rural locations and in veterans clinics, whether or not they have access, whether their doctors are incorporated as some of the investigators. And then finally, who's communicating the results to the patient? What are they going to benefit? How are they going to benefit? And what safeguards are there to prevent them from being abused as has been done in the past? So all of these issues become very relevant, both in terms of COVID-19 and in subsequent clinical trials. I think we really have to consider how to do the studies differently so that there's both trust and access.
Thank you, Andrea. That's a very, you highlight sort of areas that we all understand are need to be prioritized going forward. And I think just very broadly, I think we're worried that there's been this sort of new introduction about a healthcare environment potentially being a more at-risk setting. So for example, doing real world studies, maybe Michael, I'll go back to you. I mean, we rely a lot on real world studies and observational data. Do you think that we're likely to see enthusiasm for that type of study go down? If we're talking about the investigators that are here today, is that an area where we think is going to be more growth, maybe demonstrated by COVID-19, or less because of this patient fear factor?
Yeah. Well, thanks, Nora. I actually think, so first, real world data is usually defined as any kind of information that's acquired outside of a clinical trial. So it could be anything. It could be electronic medical records, it could be pharmacy and medical claims data, it could be social media, it could be wearables. Or longitudinal observational registries, for example. So COVID was a perfect example where these real-world data were really the first to inform what was going on with COVID, and they were critically important to initially help us understand just the extent of the problem, the magnitude of the disease in terms of morbidity and mortality. So these real-world studies are critical. It also highlighted the fact, and even looking at the initial responses about treatment, what treatments could be utilized, right? Real world data was the first out there before you could even get a randomized clinical trial up and running. And many of them contributed to our understanding of how the best ways to initially manage COVID. Of course, there were some issues with that. As was pointed out, several studies, real world studies had been withdrawn from major medical journals because of irregularities in how those studies were performed. But those aside, I think still real world evidence was critically important to understanding what's happening with COVID, and it will continue. I think that you've talked about innovation earlier. The FDA has really embraced real world data, initially with the 21st Century Cures Act, but now with COVID, they've started something called the Evidence Accelerator to bring together large groups of stakeholders to really work on real-world evidence, to develop common tools, to develop common data sets, to understand more about COVID. And that's just the first step. I think COVID was the proof of principle, and I think now those kinds of incubators or accelerators will really filter down to other disease areas. So that's one example where innovation will continue to take place in real-world evidence, and I think it'll continue to be important.
Very good. Thanks, Mike. Are there any other comments related to this idea of the patient perception? And I'm wondering, Anna, if you have any comments on just outside of the idea that we're going to have these patients that we're going to try to recruit now into new studies. What's the perspective there? What do you think we're going to have to do to have patients feel comfortable doing clinical research?
Well, there's several things. Like we try to reopen the clinic. Some of the patients are hesitant about coming to the hospitals, coming to the clinic because they worry about the safety. They want to stay at home. So we have to, for studies in which we need the participants to come in, make them feel that they will be safe. And we also need to make sure that they feel like if things change, that we have the ability to sort of adapt and continue to take care of them, particularly if we enroll them into a treatment trial, that they would not have the treatment interrupted. And I think that it's also important for us to sort of try to get them adapted to using remote data entry and give them all these instructions. It's just like we do in clinic. Now we try to get everyone to sign up on a patient portal, instruct them how to do video visits. We have to do it, give patients the same instructions if they participate in research.
Yeah, absolutely. I'm going to shift gears because I've got Dr. Shurker here from the NIH, and just I thought it was very interesting. Dr. Allen presented this data that the actual number of submitted applications actually has not gone down, and it raises two questions on that. Dr. Allen, I'd like your perspective first. Do you think this is because maybe people had a little bit more time to write? Our duties changed, but maybe there was some opportunities there as well. So I do, and especially I think as people were juggling these new kind of roles that they have, do you think that maybe there was this opportunity to pause and actually do more writing? Do you think that that's also possible?
I definitely think it contributed. I think, as I said, that was a bit of a wave from prior work. So when you submit a grant, there's a lot of preliminary data that goes in it. That was not obtained between January and June for sure, or May. That was probably partially the result of some extra time on their hands and really having to focus on something that can be done from home in a flexible time where you can juggle several activities. I think it was reassuring, but I'm honestly looking forward to the October data because that'll be more telling. And I have to say that was not data to include COVID grants, so that was reassuring.
Right. So Dr. Shurker, can I just ask you there's two things. One is the NIH actually sponsors a large, multi-center networks where I'm sure COVID has had some impact. So just the perspective of a sponsor in terms of those studies and how you viewed it and how you've really tried to adjust to be able to accommodate that kind of change in your cohort and your clinical trials.
Yeah, thanks, Nora. So, the NIH has been very aware of the impact that this pandemic is having on our investigators and has really been quite liberal in changing policies and trying to help people to cope with the situation. Specifically within our cooperative agreements or our large networks, to a large extent, we were at the mercy of the institutions and their IRBs as to what kinds of activities would be allowed. Practically, we've had to modify protocols. As Elena discussed, and Anna as well, there was a lot of changes that allowed more remote visits, allowed more remote consenting, follow-up, laboratory biospecimen collection. But in a lot of situations, the resources really didn't exist at the hospitals because people were redeployed, people were not physically working. There are HIPAA considerations, although they were relaxed to some extent as far as allowing people who were working off-site to be able to contact participants. But as I say, for the most part, we had to abide by the local the local rules and the local ARBs. One thing that we have generally advised is that instead of making these temporary changes to protocols, we've kind of embedded changes that can be activated when and if there's a second or a third phase or another pandemic somewhere down the road. So I think that as a result, protocols have become a little bit more durable.
And probably changed in a more permanent way to be more flexible, it sounds like.
Right.
I mean, now that I have you, one of the questions that just came in, and I think it's a really important one that maybe many want the answer to, and that is just about sort of the thinking about funding at the NIH and maybe NIDDK. There's been a lot of resources put towards COVID-19 grants. Can you give some sense of what you think the future looks like in terms of non-COVID grants in the future? Do you think the funding line is going to be about the same? Do we anticipate an increase? Do you have a crystal ball there you want to share with us?
So actually, it's a good point, good time to mention the resources that are available online. Probably the gateway, the easiest thing to remember is nih.gov/coronavirus. And that'll give you a link to policies, it'll give you a link to funding opportunities, as well as results and comments from various directors and institutes and various other things. And there's a launching pad there to get information specific to grantees. The availability of funds really is dependent on appropriations, and there have been some emergency appropriations largely related to development of diagnostics and therapeutics in a very rapid way. A lot of those have gone specifically to NIAID. NIDDK and most other ICs have had announcements for what we call competitive revisions. In the case of NIDDK, there was an OC that allowed people who had the ability to do COVID or SARS-CoV-2 related research, but it was outside of the scope of their existing grants to apply. Unfortunately, the amount of money that we had to support these in the first round were limited. It was really a matter of repurposing funds, and you've alluded to that, that may have been used for other purposes. Certainly, we recognize that medical research has to continue beyond COVID, and there's going to have to be a balance in funding priorities, between COVID-related and non-COVID-related research. But as far as how this is going to happen or what specific programs are going to come, it really is going to be somewhat dependent on the next federal budget or appropriations as they come.
All right, thanks, April. We're almost at the hour. I do want to come back to thinking about the early investigator to, I think we're always very thoughtful about our future. And Elena, I think you highlighted some of the challenges in that early phase of your career, or where you're sort of in that transition period in particular. And I just wanted to know if you have any sort of, advice to your colleagues that are really at your stage in terms of some of the things that have really helped you to sort of weather the COVID so far. And I think to share those, and then I'm going to reach back to the rest of the panelists to give a final word or two about some take-home messages. You're on mute there, Elena.
Thank you. In addition to the opportunities I highlighted, I think to me it was kind of a eye-opening experience because it highlighted that if we, and I think Anna mentioned this, a balanced portfolio of research is important, right? So prospective, enrollment, interventional, longitudinal studies are very important, but if we have just that in our career, we are subject to changes like this that are external and we cannot prevent or cannot control. Luckily, I do a little bit of real-world database type of stuff too, so I could shift to that, to grant writing. So my advice is to keep opportunities open. And my second piece of advice is to start thinking broadly and more, device-oriented, database-oriented type of research, because it's not without fault, but I think that will eliminate some of these barriers. We'll have more of a global capture of patients. So we have to think in how we think, in shift in that thinking in research. And I'm in that transition personally too, but it's going to be universally applied.
That's a terrific recommendation. That's a wise, you've already gained something that's very, very useful for your entire career, I guarantee you. We're going to close, but I'm going to reach to each of my panelists and just, our webinar today was really to get a lay of the land and how it's already shifted and changed. But I want each of the panelists to kind of close with, what do you think, if we just kind of look a little bit ahead, what is going to be one of the lasting changes that we see as a consequence of COVID that you think is a benefit or something that really, as Anna mentioned, that disruption that ultimately leads to an innovation or an advance that is going to be like moving from, driving to getting Uber everywhere. So maybe I'm going to start with you, Mike. You have to unmute.
Thanks, Nora. So, yeah, I think we've heard that there's clearly been a lot of innovation going around in how we perform clinical research. I think this will continue. I think that all of us have done telehealth. Patients are learning how to do it. They're going to adapt it. It's going to help with doing electronic patient-reported outcomes. It's going to help with doing electronic consent. I think we can incorporate telehealth into our clinical research in the future, not just our clinical research, but also in our patient care. So that's here to stay, I believe. We've all been able to do that. The other aspect is that, these webinars, normally we would have traveled somewhere to do these, or we would have done an in-person meeting. I gave a seminar in Brazil, for the Brazilian Hepatology Society last week for 90 minutes. I normally would have traveled 5 days to accomplish that. And yet I think we got the message across on the webinar. We miss out on networking, we miss out on seeing our friends, we miss out on the hospitality, but we realize we might have more free time to write grants and papers because we're not traveling as much. So.
All right, great. Thanks, Mike. April?
So the message that I'd like to leave is that the extramural staff at the NIH is all working. Most of us are remote, will be for the foreseeable future. While the concentration is being to get the intramural staff and labs back up and running. But, we're aware that people are having a hard time and there's a lot of hardship out there. And I just want to, leave you with the message to talk to us, communicate with us. We're from the government, we're here to help. And, to the extent possible, we're very flexible and really want to keep things going. We've invested a lot in your research programs and in your labs, and we want to do everything to keep them going.
Great. Thanks, April. Anna?
So I think one of the things that I have recognized is that when we plan studies, we want to collect data on everything, just in case. We also want to collect a lot of samples, just in case. In the end, we always, when we start writing papers, only analyze and include a very small proportion of the data that we collect. We still have many studies in which there are samples sitting 20 years later. We haven't depleted them. And so I think this is a time when we can seriously ask ourselves, what is truly needed? So that it's going to be less costly. It's also less burdensome on the patients. It's less burdensome on the research team. We can do it leaner and still get the same science without sort of, saying, just in case.
Great. Thanks, Anna. Terrific. Andrea.
I agree with everything that's been said. And I would just say, I think in the context of this pause that everybody's been forced to take, it's going to lead hopefully to more collaborative research. And it also gives people a chance to build those bridges that I was talking about with other people in community health centers, in rural areas, to really diversify the patients that we're able to reach. Technology is going to allow us to do things we weren't able to do before. And then my final thing to say is just for the investigators that are really feeling very anxious, you can only control what you can control, and that you need to show yourself some grace and recognize that there's a lot of things you can't do anything about. Just work on what you can do and relax a little bit.
Excellent. Thanks, Andrea. What words of wisdom there. Elena, last word.
Thank you. I don't know if I have anything more to add. I think for all of us, it was a great reminder of the fact that the only thing guaranteed in life is change. To me, it was a good learning experience. I hope that for investigators at my stage, it's not going to be a disruptive pause that stops a career. I want to express the optimism that I think we can move through. We will have to just change, but I think we still can do it. So I don't know if I know how I will do it, but I will not lose my passion. So I want to enforce that into all the other colleagues that are at my stage.
Excellent. I think that's a perfect way to end, because I think if I would have any final word, it would be for those young investigators, lean on the investigators that are a little bit ahead, because we're here to really ensure that that next generation continues to thrive through this change. I want to thank all of the speakers and panelists for joining me today. And I really want to thank the audience for their participation and for the terrific questions that they provided. Thank you all. And I will close and just remind you that this will be available on the AASLD website. And thank you again for joining us today.